we actually get started, I want to just announce this session that we're going to be holding on May the 18th. It's an all-day session about business-related things for young physicians and residents and young guys who are out in practice. Basically, I've just learned over the years that you don't get any training in business-related things in medical school. Usually we don't take business classes in college, or very many. Very few of us really are prepared for anything in the business world when we get finished with our training, and we're often taken advantage of by people that know a lot more about those things than we do. And so I've educated myself over the last number of years, both the hard way, but also actually getting a couple of MBAs, and I actually even got a JD degree. So we kind of came up with the idea to put on an all-day session. I've given a couple of lectures over the years. I think you guys, some of you may have attended a lecture I gave at Perry's either last year or a couple of years ago. And it's a 1 hour, that's like a 1 hour evening talk. Well, this is a full day talk, and it's not just given by me, it's given by a lot of other experts like lawyers and accountants and bankers and people like this that are going to come in and give you a good full day's bit of information. And you're welcome to, it's free of charge. We are getting a location. We think it's probably going to be maybe University of Texas at Dallas, but we're sort of finalizing that. Won't cost anything. You're free to bring your spouse or your significant other if you want to bring a person that wants to learn about this and kind of help you with this. I know my wife has helped me out many times over the years with business related stuff. So we're making this open, and it's something for you guys. So hopefully you won't have a lot of the issues that a lot of us old guys had to deal with when we first started in practice. So today what I'm going to do, a little bit different format. You're welcome to volunteer if you want, but we sort of had some feedback that because these things are recorded and put in the real world, that so people don't want to say, well, hey, I missed that, and it's sort of on the internet. I can kind of understand that a little bit, although certainly this is an educational forum, and nobody's expected to get everything right. Mainly we're just trying to learn here. But I'm going to go through these and explain to you what I'm seeing. And so you'll see I'm going to go through an approach like I would be doing if I was looking at this under the microscope. And this is what I want you to think that you're going to do. And then you need to quiz yourself on this. If you're not getting it by somebody like me asking you, you got to do it yourself, because you guys just had your in-service exam just last week, I believe. And you were presented with some dermatopathology, and you have to pass the dermatopathology part of the board examination, or you fail the entire board. So it's very important to make sure that you feel comfortable and confident about this when you're on there. And I like the old saying, bleed in practice and sweat in battle. So that's what I would strongly recommend, that you make it as hard as you possibly can on yourself while you're studying. So when you get into the exam, it's a breeze, or if it's not a breeze, it's just maybe a very small gale. You don't feel like you're in a hurricane and you're getting, totally destroyed. So anyway, so when I'm looking at this, first of all, I always ask myself, what kind of biopsy is it? It's a punch biopsy. It's from volar skin, not volar skin. It's from hair-bearing area. So we know that this epidermis is abnormal. It's markedly thickened. And maybe if this was on volar skin, you might get a little bit of that acanthosis there, but this is clearly abnormal here. And it's psoriasiform. You say, well, is there any it's inflammatory neoplastic process? It's got a slight amount of inflammation, but doesn't have a whole lot. So if it's inflammatory, it's maybe going to be a psoriasiform dermatitis, but it's pretty subtle. And then we look at the epidermis. It's markedly acanthotic. It's got psoriasiform hyperplasia, but it's kind of irregular. These aren't these nice, long, thin epidermal rete that we see with psoriasis. And then we look at the cornified layer, and it's markedly thickened. And in some areas, you get these kind of large zones of some different appearing cornified material. So we're going to higher magnification. And if you look carefully, you can see there's an area where there's a loss of the granular cell layer just right here with this column of parakeratosis with no diskeratosis beneath it. And there's another one over here. And so without any history at all, you might, they wouldn't give you something like this without some sort of nudging a little bit, because they might show you a clinical picture and then show you this and then ask you some differential diagnoses, because this is the differential diagnostic pattern of a psoriasiform dermatitis. The problem that makes it more challenging is that you've got these broad zones of parakeratosis with no neutrophils, and you don't really see that in psoriasis. You don't see it in other psoriasiform dermatitis, like, say, the deficiency diseases, pityriasis rubropilaris, where you get the alternating ortho and parakeratosis both vertically and horizontally. And then you've got this markedly thickened cornified layer. So what this is an inflammatory linear verrucous epidermal nevus. And the classic findings, it does look psoriasiform, irregular psoriasiform hyperplasia. You do get these broad zones of parakeratosis, and they don't usually have neutrophils in them, no mounds of parakeratosis with neutrophils. And even though you do get some alternating ortho and parakeratosis this way, you don't really get it running north and south. So it's a good example of this entity. Now, when you see epidermal nevi in a person, and you biopsy it, it's kind of like the Forrest Gump, in a box of chocolates. You don't really know what you're going to get until you look at it under the microscope. You just get, somebody comes in with a linear, kind of crusted, scaly plaque that's going down one of a dermatome or Blaschko's lines, and then you see it and you say, well, that looks like an epidermal nevus. It could be a number of things. It could be this. It could be so-called linear Dariè's disease, focal acantholytic dyskeratosis. It could be epidermolytic hyperkeratosis. If you see little patulous ostia, obviously you might be dealing with the nevus comedonicus. Other, just a papillated epidermal nevus, generally it looks a little bit more like kind of a cluster of skin tags. And then if you saw like a nevus sebaceous, usually on the scalp with loss of hair and the yellowish color and the verrucous appearance to it, those kind of look a little more characteristic. But if you get one of these post-zygotic somatic mutations on the glabrous skin, they can look like a lot of different things. So you have to take a biopsy and determine that. So what they might do is show you a clinical picture of an obvious epidermal nevus, biopsy, maybe photograph right adjacent to it, and say the best diagnosis is, and then maybe they might list some of those various things and expect you to be able to tell that this is not the reaction pattern of FAD or epidermolytic hyperkeratosis or any of those. So this is what you'll see if you do encounter an inflammatory linear verrucous epidermal nevus. It's a good example of that. Okay, this is another one that you're going to encounter on the exam too at some place. You might not encounter that last one, but this one you most certainly will encounter somewhere on the exam. And so we've got a punch biopsy once again, and it looks like it's an inflammatory process. There's a relatively sparse infiltrate in the dermis, but clearly the abnormality is going on in the epidermis, and that's abnormal. There's a blister. And so when we think of our 9 patterns of inflammatory skin disease, which I like just the 9 patterns. When Dr. Ackerman did the second edition of his book, he added a lot of additional patterns, but most of those are sort of sub-patterns. So this one will be intraepidermal. And we know that the 3 main ways of getting intraepidermal blisters are spongiosis, acantholysis, and ballooning degeneration. Those are the 3 main ways. And there's some other ways that I'm sure you have studied at this point, but those are the 3 main ways. And so we don't want to overcomplicate things. We want to kind of keep it simple. And so we're going to look in the epidermis and we're going to see which of those 3, or maybe more than one of those 3, is causing this. And you can see that the cells are not grasping one another anymore. So they're acantholytic. These cells are falling apart. They're not adjacent to one another. The desmosomes have been lost. So this is acantholysis. So clearly it's an intraepidermal acantholytic process. Now, the other thing you have to look at is look at the cells themselves and see if there's any abnormality there too, because you can get combinations of things. For example, in this diagnosis, which is herpes virus infection, you get both ballooning degeneration and you get acantholysis. And that's why when you do a zinc preparation, where you take the contents of the blister and smear it and put it on a slide and stain it with Wright's Giemsa stain, you're actually seeing these acantholytic ballooned keratinocytes. Now, so you're going to encounter this on the exam somewhere. They'll have a photograph, maybe a zinc prep, and they'll ask you for the diagnosis that you're supposed to be able to recognize that this is herpes virus infection. They might show a picture of somebody with zoster and ask you something about, what kind of workup would you do on this patient to see what kind of systemic illness they might have, et cetera. But they definitely are going to show you something about herpes on the test. So you need to be able to recognize this pattern. And when you look at the individual cells here, you can see these are the early viral cytopathically affected cells. You can see that the cytoplasm is kind of clear. The cells are swelling, they're filling with fluid, and then they start becoming discohesive, as you see over here, and they start floating in the blister space. And then and then here you can see that a lot of these have many nuclei to them. So this is a multinucleated cell. Here's another one up here. Probably came from a dark-skinned patient because this dark material is melanin. So that's not part of the disease. It was just the person's background skin type was dark, maybe type 4 or 5 skin. But you can see the nice multinucleated epithelial giant cells here. So this is pathognomonic of herpes when you see this. Now, what they might do is show you something like this, and then they might expect you to be able to distinguish this from certain other viral diseases. So the most common pattern of viral disease in the skin is ballooning degeneration. So when we see, for example, Coxsackie virus, hand, foot, and mouth disease, that's also a ballooning intraepidermal vesicular dermatitis, but you don't get the acantholytic change there. You see the cells are swollen, they're ballooned, and you get these pink intranuclear and intracytoplasmic inclusions. Molluscum contagiosum, a pox virus infection. There you also get ballooning degeneration, and you get the Henderson-Patterson bodies inside the cells. Those are pink. And if you see electron micrograph, those actual viral particles you can see in there kind of look like a little bread loaf in there. That's a DNA viral infection. And a lot of these diseases that give you the ballooning degeneration like this are DNA viruses, as opposed to the ones that give you a more biliform eruption like rubella and measles. Those diseases, those are more RNA viruses. But these, as a DNA virus, monkeypox or mpox, that's also gives you a ballooning degeneration, but once again, you don't see the acantholysis like you see here. So they might show you this and then ask you the differential diagnosis of some other viral conditions. So make sure you can distinguish among these. I don't think they're going to ask you some of the kind of historic information like the Cowdery bodies and all those kind of things. Those are just cytologic names for these cytopathic effects within the cells. It's not really all that important. But the most important thing is that you can recognize the acantholysis and the ballooning generation here, and then know some of the other information about herpes viruses. Okay, a little different pattern here. We've got another punch biopsy, and the pattern at low magnification, it's very diffuse, nodular and diffuse, okay? And that's one of the reasons why we like to get a punch biopsy of inflammatory skin diseases. If you just get a shave of something like this, you really can't even assess this part of it down here. So, and this is important because this disease is associated with this pattern of inflammation very commonly. And you can see a low magnification, it's got not a suppurative granulomatous pattern, it's got dark cells. So a lot of these are going to be lymphocytes. And that's kind of important also because some of these conditions that give you this diffuse infiltrate like this, they give either lymphocytes or neutrophils or whatever. But in this case, when they give you, you'll see when the diagnosis, I show it to you in a second, it's very common to get plasma cells and lymphocytes more than neutrophils in this specific condition. The epidermis is a little bit hyperplastic. This could be from near volar skin. I don't really see any hair follicles here. So this might just be maybe close, say, to the hand or possibly the lower extremity. It's pretty thick biopsy. There's a lot of dermis here. There are some pale cells, so there's probably going to be some granulomatous inflammation. And then we'll go to higher magnification. You can see it's got these areas here where the cells are kind of pale, admixed with lymphocytes, and also some plasma cells. Now, some nodular aggregations, you can see some plasma cells in this infiltrate as well, which is fairly characteristic of this entity. And then it's kind of not as easy to appreciate as some examples of this, but if you look carefully inside these cells, you can see there are these little tiny dots that are lining up at the outer rim of this clear cell here. That is a histiocyte, and it contains intracytoplasmic organisms. And when they kind of form this little almost Ferris wheel or marquee phenomenon like this, that's very classic for Leishmaniasis. Now, this pattern doesn't give you as many of those marquee signs as we see in the classic form of New World Leishmaniasis. So this might actually be a case of Old World Leishmaniasis. That's not a 100% guarantee, if you will. But when you see the organisms kind of present more diffusely in the cytoplasm instead of forming that nice marquee sign, that favors the diagnosis of Old World Leishmaniasis. So this might have been, say, maybe a military person that had been stationed in the Middle East or something. Maybe they got infected and then came back to the United States. Most of the cases that we see today are individuals that come from South America, Central America, so that sort of thing, and they bring it with them across the border. But it is actually indigenous now in Texas and in a few other southern states in the United States. So we do see it here. We see cases of patients that never traveled outside the United States. They're maybe gardeners and this sort of thing. And we actually wrote a paper on this a number of years ago, and the CDC and some others came down and they actually demonstrated that the fly vector that causes the organism has migrated north from Mexico. So maybe because of global warming, not sure why, but the fly is actually now in Texas. So we do actually get cases even as far north as Dallas area, not just San Antonio and Austin, of this disease. So this is it's kind of hard to appreciate just with the scanned slide image here. It's one of the disadvantages of this versus an actual slide where you can go at higher magnification. But you do need to know the differential diagnosis of the intracytoplasmic microorganism diseases, things like rhinoscleroma, things like granuloma inguinale, histoplasmosis, Penicillium marneffii infection. Those are all things that can cause this intracytoplasmic parasitosis, if you will, of histiocytes. So make sure you know that. Obviously, if they were going to show you something like this, you'd be able to see the organisms a lot better than we're showing them right here. Or they might show you a good case with some really classic marquee signs that you could see with relative ease. Or they might even show you maybe a histoplasmosis case with some special stains. So just make sure that you're able to diagnose these intrahistiocytic diseases, because you'll definitely be encountering that almost for sure. Okay. I think we'll look at the middle one here. All right, so we have a punch biopsy and and there's really not much of a granular cell layer or even much of a cornified layer here. So we say, well, that's sort of unusual. Usually we see stratified squamous epithelium's got a cornified layer when it's a biopsy of the skin. And so this might be from a mucous membrane. Maybe it's, say, from the lip or something like that, which, and one of the reasons we like to do that is that every single bit of information that you're given on a slide is a clue to the diagnosis. So, first case of that inflammatory linear Verrucous Nevus, well, we knew that was not normal volar skin because there were hair follicles in there. Well, here we say, well, this is on a mucous membrane site. So what's going on here? Why'd they biopsy this? Because they're only a relatively, there's a fewer number of diseases that we encounter in dermatology that involve mucous membranes as opposed to things that affect the glabrous skin, like, allergic contact dermatitis or psoriasis and those kind of things. So when you biopsy somebody's, lip or maybe a perianal area or something like that, you're biopsying it either kind of a neoplasm or maybe there's something in that area that sort of was done for some reason. So we look at this at low magnification. You should be struck by the fact that it's very pale here. So something's going on. It's not normal to look at a biopsy of any part of the body and it to look this white like this, and it's got holes in it. Well, that's abnormal. And that doesn't even look like that really is a biologically endogenous sort of process. When you get these irregular sort of shaped holes, you go, well, gosh, this might even be something exogenous in a way. And it's diffuse. It goes all the way from the top of the probably lower lamina propria here all the way to the bottom. So we're going to higher magnification. You need to sort of have a differential diagnosis when you look at low magnification. You see that things kind of look white. You know, is it lipid? Is it glycogen? Is it mucin? Is it something that was maybe injected into the skin exogenously? You know, and so you might even begin to think that maybe that latter conclusion is correct, because we've got these big giant holes here that don't belong. So something may have been injected here. As we go to highest magnification and you look at these cells, these are actually histiocytes. And if you look inside them, they have these little tiny small bubbles inside them. And that's really classic for silicone injection. So what happened here? It's a mucous membrane. And these large areas here, even though there's no silicone inside these, may have been some kind of an impurity that was injected into this area also. Usually silicone, when it's industrial grade silicone that's injected by a high quality cosmetic dermatologist, they use just little tiny drops that they put in, usually in the level of the lower reticular dermis and the subcutaneous fat. They don't inject large amounts like this. And you would almost never, in a well done silicone injection by someone who does it for a living and they know what they're doing, you wouldn't get these large holes like this. So this is almost certainly done by an amateur, probably somebody that was injecting non-medical grade silicone. And I wouldn't be surprised if you polarize this. You might even see some polarizable foreign material in here as well. We don't really see a lot of that just on the H&E section, but this is way too much silicone for something that was done appropriately. So this is probably done by, you know, someone somewhere outside a medical practice. And it's probably the lip. So they probably wanted to have their lip expanded and injected to made look larger. And, you know, silicone is really not the right filler to inject for that. That really should be more, you know, hyaluronic acid or something along those lines. So it's not the right filler. So this is a criminal situation here. But this is what silicone looks like. And they very well would possibly want to test you on the histologic features of the various fillers. And so you need to know what they look like. So silicone looks like these little tiny bubbles. So I don't know if there's an old song by maybe Wayne Newton, I guess, way back in the 50s. And it was tiny bubbles. You're talking about the tiny bubbles in a champagne. And so you're looking at champagne, the little tiny effervescent bubbles, not the bubbles you see in 7-Up or Coke. Those are way too big, or Topo Chico. The little teensy tiny fine bubbles that you get with a very fine champagne. That's kind of what you see with silicone. They're inside the cytoplasm of these histiocytes here. Now, some people confuse silicone with silica. Silica is a molecule. Silicone is Si, it's the element. And it's theoretically supposed to be non-reactive inside, you know, the human body. It actually, as you can see here, probably has some impurities, but if you get pure industrial grade silicone that's very pure, it's not really supposed to really cause too much of an inflammatory reaction. Sometimes it may oxidize or change inside the skin, and then people get a secondary reaction, or maybe there's microscopic amounts of impurities that are there. So people do get silicone granulomas even when it is medical grade, but it's different than silica, which is glass. And we see that very commonly. People that automobile accidents, they get these chunks of glass, polarizable material, and they get a suppurative granulomatous reaction, or sometimes even a sarcoidal granulomatous reaction to the glass. So that looks different. So don't confuse silica with silicone. You may have heard the term paraphenoma. That's another, and this is kind of closer to that. That's where people inject things that contain lots of material in there. They contain sometimes silicone like this, and they contain wax. They may contain all sorts of things in there. And again, those are things that are injected by people that want to enhance their skin. They want to puff it up, and it's not done by a medical professional. It's done by someone, and you almost always see polarizable foreign material when you look at a so-called paraphenoma. Hyaluronic acid looks kind of like blue-gray jello injected into the skin. It's basically like mucin, like hyaluronic acid we see like in, say, the mucin and lupus erythematosus, for example, but it's formed into little small aggregations, and so it looks really like little packets that have been injected in there. If you look at the things like poly-L, the methacrylates and those kind of things, those look like little BBs. They're little round plastic-like structures in the skin, and radius is calcium. Basically, you see little small calcified BBs in the skin. So you need to know what those fillers look like. Each one looks different, and this is what you see in silicone. Okay. Sometimes we'll get biopsies of breast reconstructions where they've had a silicone breast implant. That looks a lot like this also. Okay. This is another biopsy where we have kind of a clear appearance at low magnification. So a punch biopsy. What part of the body are we on? Well, notice how thin the epidermis is here. And it's got a basket weave cornified layer. It really doesn't have too much even of a epidermal reedy. And there's not much inflammation, at least we can see a low magnification. There's something going on here, but there's not a whole lot of, there's not a lymphocytic infiltrate, there's not neutrophils, no suppuration. So what part of the body are we on? Well, we're probably maybe in an area where the skin is very thin, like the eyelid. Another clue. So what diseases do we see in dermatology where the eyelid is involved? Well, there's not a ton. So we're going to, let's go to higher magnification. We're going to sort of focus on, okay, well, this may be in the eyelid. It's got clear staining cells in the dermis once again. And so just like we said before, we start asking ourselves, why does it look white or clear at low magnification? Well, in this case, when you look higher magnification, there's no tiny bubbles here. You've got what looks like foam inside the cells. And so these are lipid-laden histiocytes. And so you put 2 + 2 together, lipid-laden histiocytes with minimal other inflammatory infiltrate in an area of the skin that is very thin, with like 4 or 5 keratinocytes thin with a basket weave normal cornified layer. No vacuolar alteration, no thickening of the basement membrane zone. So it's not thin because of an inflammatory process. This is normal. So it is the eyelid. So histiocytes with foamy cytoplasm in the eyelid, diagnosis, Xanthelasma. Pretty straightforward. So they could very easily show you this. This would maybe be, if they did show you something like this, they might give you a clinical picture to go along with it, because this, if you just saw this alone, the other types of xanthomas theoretically could be in the differential diagnosis. In an eyelid situation like this, probably never. And they would probably show you something like this, and then maybe ask you a second order question about what kind of workup would you do for the patient to evaluate their lipid status. So, patients that have xanthelasma have higher incidence of hypercholesterolemia, can end up getting, coronary artery disease. They get arcus senilis around their eyes. So you want to make sure that you don't miss a person with cardiovascular disease that's got xanthelasma. So that's probably the most important thing there. Now, is there anything, if you're going to look at the differential diagnosis between this and other types of xanthomas, a nodular or tuberous xanthoma, one of those, doesn't give you these small little clusters of these foamy histiocytes like you see here. That's a large nodular aggregation of foamy histiocytes. So this really doesn't look much like a tuberous xanthoma or any of those kind of xanthomas. It doesn't really look much like an eruptive xanthoma. Now, if you just had these cells alone, you can see those in eruptive xanthomas, but you almost always in an eruptive xanthoma, because they do actually come up in an eruptive fashion, come up very quickly, you'll actually see these histiocytes with the lipid that have actually ruptured, and you get extracellular lipid. And extracellular lipid, especially when it's triglyceride, which is what's the main circulating abnormal lipid in eruptive xanthomas, it looks bluish gray, and it looks a lot like mucin. And it actually can simulate granuloma annulare histologically. So that's kind of a pitfall that we see sometimes. If you can usually tell the difference because there's really no lymphocytic infiltrate, and you don't get any multinucleated histiocytes. And if you look carefully, you'll see some of the intact histiocytes with the foamy cytoplasm. But it can simulate granuloma annulare. So just remember that it's kind of a pitfall in diagnosis when you're just looking at it under the microscope. Okay, so that's xanthelasma. So we had a clear biopsy because it had exogenous material in it. This one's got endogenous material, and one's lipid and one's silicone. So you've got two different examples of lesions that have clear cytoplasm. Okay, now we've got a punch biopsy. Okay, epidermis looks reasonably normal here, a little bit sort of acantholytic papillomatous. Is it an inflammatory or is it a neoplastic process? Well, we don't really see a lot of inflammatory cells at low magnification. We do see some little small holes up here. And so if we see something like that at low magnification, we say, well, maybe it might possibly be vascular. If it's a neoplasm, it's a punch biopsy. It looks like there's small aggregations of cells, that individual ones are quite symmetrical. It doesn't really look like a diffuse, poorly differentiated, poorly circumscribed lesion, so probably benign. So we say, well, it may be vascular, but we're not sure. We'll go to higher magnification and prove that when we go to higher magnification. So once again, we get here, the epidermis is completely normal. We don't really see any abnormalities there. It's got a basically cornified layer. And here at higher magnification, we do see these little small vascular spaces here with these endothelial cells surrounding them. And we see multiple little aggregations. There's one here, there's one here, there's one here, there's one here. This process is relatively superficial. It does go to the bottom, but the bulk of it is present at the top. As we go to higher magnification, we look at the individual endothelial cells. We don't really see any atypical mitotic figures. We don't see any pleomorphism. These are just small epithelioid and maybe some slightly fusiform cells here. We have a few prominent endothelial cells here. But notice that they're forming these little sort of tufts, if you will. And this is pretty classic for a so-called tufted hemangioma. Now, they could show you this alone, but given that there are some pediatric dermatologists on the American Board of Dermatology, and they like to be represented on the exam, obviously, they might show you something like this, and then they might show you a picture of this, which be maybe kind of a purplish plaque on the trunk of probably an infant. And they might describe it and say the lesion was somewhat painful, or the child acted sort of as if it was somewhat painful when it was touched. And they might ask you the differential diagnosis. And the best diagnosis here is a so-called tufted hemangioma. And the classic thing of a tufted hemangioma is that you see these small tufts of blood vessels. It's almost like each one is forming its own little individual hemangioma, if you will. And they usually do present as a plaque. They're usually diagnosed in young infants, or usually they're probably congenital lesions, but they're not really thought to be in the same exact family as some of the other types of hemangiomas. The main features about this is the fact that it's got these classic sort of tufts. Now, they might ask you the information about the GLUT1 stain, whether it's present in juvenile or congenital, and the niche and rich sort of thing. I'm not going to go through all that right now, but I would strongly recommend that you become familiar with that, because they like to ask that, and they like to get that stain, and they like to see whether it's a juvenile versus a congenital lesion, whether it's got the staining pattern of the GLUT1 or not. And we do that occasionally in our laboratory when we're requested. So that's something that you should at least go through, learn that, make sure you understand and feel comfortable with that. For this, the most important thing is just to recognize the morphology. Now, they might theoretically put some differential diagnosis options on something like this for you. They might say pyogenic granuloma. Well, this isn't really pyogenic granuloma. Pyogenic granuloma doesn't give you these individual little tufted blood vessels like this. This is somewhat lobular capillary proliferation, but PGs give you like a solid nodular aggregation that looks like granulation tissue. Would not give you these small little tufts like this, and certainly the clinical wouldn't look anything like this in a pyogenic granuloma. They might put poems down. Now, that's kind of almost getting a little bit unfair, because poems can give you so-called glomeruloid hemangiomas. And what happens in poems is that you get small little microthrombi within these capillaries, and it causes localized ischemia. And you get a secondary vascular proliferation that develops around the thrombosed capillaries. It's almost somewhat analogous to the vascular proliferation we see in atrophy blanche, where you get the abnormal fibrinolytic pathway and deposition of fiber, and then secondary vascular proliferation. You get the same sort of thing happens in poems. So for poems, you would really need to see thrombosed blood vessels here. You can get a glomeruloid tufted-like hemangiomatous proliferation, but you would necessarily need to see the immunoglobulin plugging the blood vessels. So that's a little bit more sophisticated. Probably wouldn't ask you that to differentiate between this and that, but this is not that because you don't see the thrombosed vessels with fibrin in their lumen. So that would be something else. I don't think they would ask acroangiodermatitis, but this would not be a good example of that because you don't see any stasis alteration here. So acroangiodermatitis is basically a manifestation of terrible stasis dermatitis, stasis alteration, where you get prominent tufted vascular proliferations, once again, associated with extensive stasis alteration. And the vascular proliferation can occur far down in the reticulodermis. It can even go down almost to the subcutaneous fat and can be associated with hyperdermitis sclerodermiformis as well. And you don't see that the stasis change here. These are just some of the dilated blood vessels that are associated with the vascular malformation here. So that is tufted hemangioma. Okay, you could possibly encounter that at some point. Okay, shave biopsy, neoplastic process. Okay, so it's small, they took a shave of it, we don't really see any inflammatory process. The board is not going to show you a poor biopsy. So they probably wouldn't even show something this small. They might, but likely not. But in any event, if they're going to show you an inflammatory process, you're going to get a punch biopsy. So if you see a shave like this, you should probably say this is probably neoplastic. Now we ask ourselves, is it benign or malignant? And if it's, in general, we look at things like, is it broad, fully circumscribed, asymmetrical, those kind of things generally for neoplasia. But obviously you can get small neoplasms, especially if they're maybe biopsying something to rule out a basal cell. Those lesions aren't necessarily large. They can be relatively small. So you have to look at other features. So you look at cytology. We ask ourselves at low magnification if it's a neoplasm. So again, is this benign or malignant? We're not sure. It's pretty small. So if it's malignant, it's going to be low grade. What kind of epithelium? Well, it looks like it's contiguous with the epidermis. And even at low magnification, you see these cells are kind of pink. So probably going to be epithelial as opposed to non-epithelial, which are things that are going to give you spindle cells and things of that nature. So as we go to higher magnification, we notice that these cells are falling apart from one another, okay? And it doesn't really look too terribly atypical, but we're going to look at higher magnification. And as we get to higher magnification, we start seeing some mitoses here, and these cells are kind of pleomorphic. And so even though it's pretty small, this looks like it's probably going to be a low-grade malignancy, especially given the fact there's some mitotic figures in here. So how do we put this together? It's got acantholysis, and it's got these atypical keratinocytes at the periphery. If you look over here, there's possibly a little bit of a solar keratosis right here that's contiguous with this. So this is a small, it's also in sun-damaged skin, by the way, so it's a sun-induced lesion, a small lesion of an acantholytic squamous cell carcinoma. It's relatively low grade. I don't think they would give you a lesion that's this small and expect you to make the diagnosis. They might, and I would hope that you would recognize the atypicality here. This does have a differential diagnosis. You can get a so-called solitary acantholytic keratosis. Those usually give you acantholytic dyskeratosis, which we really don't see that here. We just see only acantholysis within the lesion, and usually don't get mitotic figures and atypia in that lesion. Another thing that can sometimes give you acantholytic dyskeratosis in an inverted fashion is a warty dyskeratoma. Once again, that lesion is going to give you acantholytic dyskeratosis with chorones, grains, so-called acantholytic dyskeratotic spinous cells and parakeratotic nuclei. We don't see that here. So I doubt that they would get into trying to ask you that because that's pretty sophisticated. But if they somehow did do it, make sure that you can recognize the classic pattern of focal acantholytic dyskeratosis, which really does not look like this. And again, you don't get the atypical cells in that lesion that you would get in this lesion. They might put in a differential diagnosis of herpes virus infection. Are these the multinucleated giant cells of herpes? No, it's acantholytic like herpes, but we don't have the classic cytologic effect that we saw earlier. They might perhaps put something like pemphigus vulgaris or Haley-Haley disease. Expect you to, somebody might say, well, gosh, it's acantholytic. Haley-Haley disease is acantholytic. You know, you should almost never use one criterion for diagnosis unless it shows a pathognomonic feature like the viral cytopathic effect of herpes that we saw before. You pretty much shouldn't use just one thing to make a diagnosis. You really should use more than one criterion, sort of like a symphony or a musical piece. You don't, you know, it's not just one note repeated over and over again. You use all of the various notes to kind of come up with the musical score. So the same thing is true with a diagnosis here. You want to use as many criteria as you possibly can to make the diagnosis, not just one. So again, if you see one thing, don't just have a reflex arc to say acantholysis, it's going to be Haley-Haley disease. Well, no, it doesn't. There's about 4 or 5 other things that can give you that, and you want to make sure that you apply criteria with skill to be able to make the diagnosis. So this is a small example of an acantholytic squamous cell carcinoma. All right, this is an interesting lesion. And again, it's probably an incisional biopsy, fairly large biopsy here. So this isn't a punch, it's not a shave. It looks like it's probably a neoplasm at low magnification, and it doesn't really look like the last case. It's epithelial at all. In fact, I think maybe the orientation may actually be more like this. So here's the fat down in this area, and it's maybe eroded or ulcerated, and it looks like there's something spindle going on in the dermis. And a lot of people talk about this as a so-called busy dermis. You can use that if you want, but just make sure you know what that means. And what it generally means, it means some kind of a diffuse proliferation of the dermis where there's almost kind of an interstitial pattern. And it can be due to spindle cells in the dermis in a diffuse pattern. It can be due to metastatic lesions in a diffuse pattern in the dermis. It can be due to inflammation in the dermis in an interstitial pattern, like in granulomannulary. So that's kind of what they mean when they talk about the so-called busy dermis differential. And as you go to higher magnification, you can see indeed it does have this relatively diffuse spindle cell process here, okay? And we look about spindle cells, just like there's 3 main types of intraepidermal vesiculation. There's really 3 main spindle cells that we think about when we're talking about a spindle cell neoplasm. Think about fibroblasts, histiocytes, fibrohistiocytic, neural, and muscle, okay? And as we look at this, so you look at the way to distinguish those. I mean, if you're looking at something like fibrohistiocytic, you look to see if there's collagen bundles associated with it, and then you look at the individual cells, and they have sort of more of like a jagged pattern in a way. They're not sort of like a delicate, lazy S swimming slowly through a nice river like you see. These are more almost kind of like they're all kind of going together in these little sort of like a posse, and they're all going the same direction, and they're kind of turning right and left. They're sort of a little bit jagged, and you've got this thick collagen here. So this is almost certainly going to be fibrohistiocytic. And if you think about fibroblasts and histiocytes, fibroblasts make mucin, and if you injure your skin, well, the first thing that happens is you get a scab, and then things start remodeling, and then fibroblasts come in, and early on they have this sort of fibromyxoid stroma, and then later they form a fibrous-like scar in this area. And so when we start looking at this, we see it's got fibrohistiocytic differentiation. It's got this sort of more primitive component, and it's got this more mature component. And they're forming these large whorls here. So this doesn't look like any kind of typical scar. We say, well, maybe it's a neoplasm of some sort. It certainly doesn't look malignant, because it looks like you've got all these well-formed, mature areas of fibrosis with this background of this more sort of loose myxoid stroma. So maybe it's some kind of a hamartomatous process. And it goes all the way down into the subcutaneous fat. And this is really a pretty nice example of what you see down in the fat of this entity here. And this is what's known as a fibrous hamartoma of infancy. These lesions often present as a skin-colored nodule. Again, they're asymptomatic. They're usually thought clinically to be something like a cyst or a lipoma or something along those lines. They usually don't even get biopsied for a long period of time. And this may have just kind of gotten larger over time, and maybe somebody was worried about it and they thought it might be a cyst or something, and maybe the patient wanted it off, and they just, or the patient's mother, because it usually is in a child, and they decided to remove this, and it almost looked like they probably tried to enucleate it. There's no epidermis here, so they probably made an incision and said, well, let's just shell this thing out of here. And they got it out, and lo and behold, it wasn't a cyst. It was actually this fibrous hamartoma of infancy. And this is pretty classic for what you see in this entity. So not sure that this will appear on your exam, but it's possible. It could. It's got, so again, the classic pattern is these zones here of fibrosis, and we talk about fibrosis being increased fibroblast, collagen, no homogenization or sclerosis of the collagen with an increased number of fibroblasts. You've got these mature areas here with this more kind of delicate early fibroblastic proliferation here with the fibromucinous stroma. And these often form these little sort of whorls of these aggregations here. That's fairly characteristic of this entity as well, and it goes all the way to the subcutaneous fat. So I think if they were going to quiz you on this, they might show it to you and then put some things in the differential diagnosis that really wouldn't fit very well at all. This doesn't look anything like a dermatofibroma, for example. Doesn't really look anything like a dermatofibrosarcoma protuberans. These are not the pinwheel storiform pattern of fascicles of spindle cells here. These are fascicles of collagen with fibroblast in them. So really doesn't look anything like that. But this is an example of fibrous hamartoma of infancy. Okay, next one's a good biopsy too. Punch biopsy. And once again, we're dealing with an inflammatory process. And if we look at this at low magnification, where's the inflammation seem to be centered? Well, it's mostly in and around follicles. And we remember that that's one of the 9 inflammatory skin disease patterns, folliculitis and perifolliculitis. So what causes inflammation of the follicle or around the follicle? So you have, and the good news is that's a relatively small differential diagnosis. It's either going to be an alopecia or it's going to be possibly some kind of folliculitis. And like we have, the most common is obviously bacterial folliculitis, but there are other things that can cause folliculitis as well. And so as we go to higher magnification, we see that most of these cells are lymphocytes, but there's also some histiocytes. We see that there's, we don't, you can't actually see the follicular ostium here, but we do see the follicle. Here's one down at the bottom. And now we've got some suppurative, little bit of suppuration and granulomatous inflammation surrounding that follicle. And then let's take a look at the other side of the specimen. Maybe we're lucky enough to get a hair follicle here, and now we actually have a hair shaft. And as we start looking in the hair shaft, what do we see? We have organisms here. And these are fungal organisms. So this is an example. This is a good example of where it shows you that you actually need to see the hair shaft in order to make this diagnosis. This is a case of Majocchi's granuloma. It could also be tinea capitis if this were on the scalp. And they could very well show you this and expect you to recognize this. And if they showed you something like this with 2 pieces, you better look at both. Because if you just look at this piece, you can't make the diagnosis of Majocchi's granuloma here because we don't have the hair shaft. The organisms live in the hair shaft and directly around it. So this was cut adjacent to where the hair shaft was. It's inflamed. So this is the perifolliculitis, but we can't call this Majocchi's granuloma. All we can just say is this is folliculitis. We can look up at the epidermis and see if there's any fungi in the cornified layer, and there's not, and there often isn't in this. So you actually have to get the actual hair shaft involved. So make sure if you've got 2 pieces on your slide that you don't just look at one. They might just put down the differential diagnosis of folliculitis, and then you might check that off, and you may miss this, and you've missed the question. So I don't think they're going to get into endothrix and ectothrix infections from a hair shaft. This does have what looks like ectothrix here, because these organisms are living on the outside of the hair shaft. But you actually get that in endothrix also, and there may be some fungi actually in the hair shaft itself here too. So it might really be an endothrix infection with also some infection of the probably the inner root sheath here of the hair shaft. So this is Majocchi's granuloma. And sometimes you get a lot of inflammation. Sometimes you don't get very much inflammation. Sometimes inflammation is right around the follicle. Sometimes it's diffuse, especially if you get like a carrion, for example. Okay. It's another good example of something that you need to know about. Here we've got a punch biopsy, and it's dark. Okay. So if actually this probably is maybe even an excisional biopsy. So this is a pretty large specimen here, and probably an excision. So inflammatory neoplastic, dark pigment here. We think maybe melanocytic. And when we think about melanocytic, our main differential diagnosis is melanoma versus nevus. So it looks relatively small. You know, it's maybe not perfectly symmetrical. We really don't see too much going on in the epidermis. As we go to higher magnification, we've got this interesting pattern of all these very, very dark cells here with some scattered lymphocytes surrounding them. And it looks sort of like a blue nevus, you know, and you say, well, gosh, it's got these heavily pigmented cells. They look like they might be melanocytes here. And interestingly enough, this is something that you probably would not get on your exam, but it's something that at least you should know about. This is an example of so-called tumoral melanosis, where someone's got malignant melanoma, it's got basically widespread disease, metastatic disease, and they start getting these black dots on their skin. Sometimes their skin turns slate gray diffusely throughout their skin, and you biopsy that, and it looks like this. And these are clumps of cells that are actually mostly melanophages, but a lot of them are melanocytes as well, associated with this. It's called tumoral melanosis. This is basically widespread metastatic disease, if you will, of circulating melanocytes. And some of these patients surprisingly beat the odds. They do better than you would think when they get this. And I'm not sure all of the biology of this. So there are people that study this in detail. And there are people at UT Southwestern that are actively studying this phenomenon. I think Jennifer Gill is studying this. But it's an interesting phenomenon, and it's associated with people that have aggressive melanoma, and they get this what's called tumoral melanosis. It's where the melanocytes are circulating through the body, and they localize here. It's not the same sort of thing as like a regional histologic metastasis of melanoma, where you see these large nodules of atypical melanocytes. This is more like a circulating melanocytes that just lodge in the skin, and these can occur at distant sites. They might even get a melanoma that may be, say, on their thigh or something, and this thing pops up maybe on their trunk, far removed from it. So tumoral melanosis. A little bit different than what we see in a completely regressed melanocytic neoplasm, like a regressed melanoma, like the thin melanoma that regresses. That melanin is usually seen in the papillary dermis. This is in the reticular dermis. And that's a broad zone of thin, delicate collagen with melanophages, not really melanocytes, melanophages. It's a little bit different phenomenon here. This is basically just puddles of these atypical cells, melanophages, but largely also melanocytes plugged in the reticular dermis more than in the papillary dermis. Okay, our last one here, and we've got a shave biopsy once again, and you can see at low magnification, it's got all of these red areas in here, and it's got an architecture that looks kind of like a wart. So if you sort of took out all these lakes here of erythrocytes and just looked at it and you back off on it, it looks a lot like a verrucous. So you can say, well, what's this lesion going to look like clinically? Probably going to be kind of a verrucous little papule. They've shaved off the entire thing. You got these large dilated blood vessels. And so this is something that could very well be on your exam also. This is a classic example of an angiokeratoma. And it's a pretty good name because it's got a keratosis component to it that looks a lot like a wart, if you will. And then it's got the angiomatous component. And usually the angiomatous component looks just like we see here, large dilated blood vessels, these relatively thin layers of endothelial cells lining them. And then in some areas, you just get really these large lakes, if you will, of erythrocytes in here. And we see these things clinically, they look like little dark jet black caviar spots. And that's the description of them. So what's the most important thing about this? So this is something, again, relatively easy diagnosis. And I'd show you this right off the bat and say, which systemic illness is associated with this, or which genetic test are you going to do to make the diagnosis here? And obviously, the most classic diagnosis is Fabry's disease, but there are about 3 to 4 other diseases that can be associated with angiokeratomas. I think biotin responsive multiple carboxylase deficiency, for example, I think that's one of them. I would recommend you should know all of the various diseases that can be associated with angiokeratomas, and where possible, know the gene abnormality associated with these conditions too. So this is something that, if it's an easy diagnosis, they're probably going to, expect you to get the diagnosis pretty quickly with histology, and then ask you some basic science questions about it. Those are called second order questions, and they're harder in some ways because you have to know 2 completely different, types of information. So you have to be a morphologist, and you have to make the diagnosis pretty quickly. And then they're going to ask you some questions that are going to make you scratch your head, that, things that are associated with this. So make sure you know that. I don't think they would ask you too much about the differential diagnosis here. I think they would expect most people taking the board examination to get this fairly quickly, and they would expect you to be able just to know the disease that are associated with it. It doesn't look anything like Kaposi sarcoma. It doesn't look anything like bacillar angiomatosis or any of those entities. Those usually, obviously KS would give you the irregular spindle-shaped cells, the promontory signs. You're dealing with the plaque stage disease. The only item that'd be even close to this would maybe be like nodular KS, and this doesn't look anything like that. BA looks more like granulation tissue. So once again, it doesn't really look like this either. Okay, well, that's it for this morning. So this is recorded, so you can go back and view it again if you want to look at it. This is how you get to our website to pull these up. I think you guys know how to do that. And then remember our business session, May the 18th. So hopefully you guys will plan to come to that and bring your friends and family. We are having another meeting coming up April 6th for PAs and nurse practitioners, but it's got a lot of stuff that's valuable for you guys. So you're welcome to come to that also. That's going to be May 6th at Hotel Zaza. So thanks for being here this morning, and we will see you again soon. Take care.